Hello and welcome to the Scotland Singing for Health podcast, produced by Scotland Singing for Health Network. I am Brianna Robertson-Kirkland and today I'm joined by two very special guests. Before I introduce them, let me tell you a little about this podcast and why we are talking about Singing for Health. Singing for Health groups support the management of a range of conditions such as respiratory conditions, dementia, Parkinson's disease and mental health concerns. In each episode of the podcast, we'll be talking to singers, singing group leaders, researchers and medical practitioners to find out more about the benefits of singing and what Singing for Health activities are taking place all around Scotland. Today, our podcast focuses on arts and social prescription, and we are joined by Deborah Hamilton, a Glasgow-based community links practitioner with the Health and Social Care Alliance Scotland, and Alison Leitch, Assistant Service Manager of the Edinburgh Community Link Worker Network, a co-chair of Scottish Social Prescribing Network and member of Scottish Community Link Worker Network. Thank you both for joining me today. So social prescription is perhaps quite a big topic, so it'd be really useful for our listeners to learn a bit more about what we actually mean by the term social prescription. And I'll throw that out to both Deborah and Alison.
There's actually been an internationally agreed definition of what social prescribing is, and it's been agreed by the Global Social Prescribing Alliance, which Claire and I took part from Scotland. So Scotland is listed as a contributor. So that shortened definition is: social prescribing is a means for trusted individuals in clinical and community settings to identify that a person has non-medical, health-related social needs and to subsequently connect them to non-clinical supports and services within the community by co-producing a social prescription, a non-medical prescription to improve health and well-being and to strengthen community connections.
It's not my favourite term, and maybe Alison will kind of, have her own feelings about that. I think I focus on the word prescription. It can really work for patients when they're sort of told to go and do something. That sometimes people are still really kind of fixed on that kind of paternalistic nature of medicine. But for me, I prefer to have a kind of more person-centred approach. And, if you're going to work with people, getting them on side in terms of what's going to work for them, what's important to them. And so prescription isn't necessarily a word that I would use. It's not my favourite, but I appreciate it can make a lot of sense to others when you're trying to get people on board. I do use it because I then go on to explain what that might mean for me. But I don't know, Alison, if you feel the same way.
It's quite a topic at the moment. It kind of comes in and out of favour. For me, when I had a caseload, I would never have described as what I was doing as I'm socially prescribing you something. They knew I was a community link worker and I was there to help them. So for me, I think the terminology is more a higher level terminal. It's a generic thing about just to highlight that it's a non-medical approach. To the people that we work with, the terminology that what we do is irrelevant. It's more just at a higher level when you're looking at frameworks or qualifications or training and things. And I think people will argue over it for quite a while to come. But interestingly, we had a leaflet that the link workers were redesigning in the summer, and they felt that some patients would actually benefit from being handed a piece of paper because they like to walk out of a GP practice with something in their hand. So again, just as Deborah said, it's about that person-centred approach. If the person that you're working with would feel comfortable with that, then you could come up with something yourself. But I think the terminology is not really important to the people that we're working with.
I absolutely agree, Alison. Yeah, that makes a lot of sense.
So what kinds of terms might you use as an alternative to social prescription, or would you use terms at all? So we've heard in the past community referral be used, for example. I'll throw that out to both of you as well.
I think when you're explaining your role, some people call it a social practitioner. Some people, it's explained as part of your role that that you would hope that the GPs kind of explained that the kind of issues that have been picked up on are not things that they can help with. So a community worker looks at things that are in their community to try and help you. So it's about keeping that person at the centre. It's about what can be done to help you to help yourself. And I think it's more around that conversation than being caught up in any terminology for the patient.
Yeah, absolutely. Within my own practice, the GPs will, they'll just name me. We've got somebody in the team, Deborah, she's non-clinical. She'll have a supportive conversation with you about what's important. I'll introduce myself as a community worker and kind of have that conversation about my role within the community, and where I can hold that knowledge of what's available, and, just open up that dialogue with someone. And then you're looking for that little spark or something that they might be interested in that you'll kind of jump on, and you can then kind of work from there. I will be honest with some folk come in and they don't have an idea and they're not really sure, and they've maybe not thought about their interests for a while or that kind of thing, and I will talk about the motivational approach. I'll kind of joke about with folk about that. I'll be like, I'll put a wee nudge in the corner and we'll maybe try stuff out and see how it goes. So folk kind of know what they're buying into.
That's really, really useful to know. So why is this work, community link workers and social prescription, why is that so important in Scotland?
I think for me, signposting in support of referrals not new. I've worked in the third sector for 20 odd years, and even though we would take referrals from folk, we would often be looking at onward referral in support of signposting. For me, it's about the location and the setting, which I think's what's really important and unique. Many of us, certainly myself working in the third sector, always wanted to know what was going on behind the scenes in the healthcare setting, a bit like that kind of curtain, pulling that back, that curtain in Wizard of Oz to see who's working here, what's going on, what does that look like. To kind of get access then into that space and get to work with that team, embed yourself as part of that team, creating a multidisciplinary approach to health and well-being, moving away from the absence of disease. And you're probably the same, Alison. You're often working off the back of the trust that patients have with their general practitioners. So you've got a kind of in there that you wouldn't necessarily have in other settings. People might not come across in other projects if they don't know where they are or how to access them. So that's for me the big thing, is about being in that location. And it really provides a great opportunity to meet so many more people.
Definitely. And I think if you take it back to where the Community Link Worker Programme, how it first came about, so it was a 2016 SNP manifesto pledge that the government would introduce 250 community link workers across Scotland, and there was early adopters, which Glasgow, Edinburgh, Inverclyde and Dundee were part of. I think there was a fifth, but I can't remember. So we were the early adopters of the programme to get it up and running. And then, by the end of the Parliament last year, the government had then invested into the Scottish Community Link Worker Network, which is hosted by Voluntary Health Scotland, and they were carrying out a mapping exercise to see whether this had actually been achieved. And I think the figures at the end of March was 249 whole-time equivalents. But interestingly enough, the feedback from the Link Worker Programme then led to a manifesto pledge to the last election, that building on the success of those link workers, that there would then be 1,000 mental health link workers, which isn't really working out that way, because local authorities or health and social care partnerships can choose what that is going to look like for their locality, which I think is appropriate. But it was interesting to see that there was something being built on 2 elections in a row. And also, interestingly enough, before the last election, the Royal College of GPs put out a manifesto pledge, and in that was a call that there was a link worker placed in every GP practice in Scotland, prioritising those in areas of high deprivation. So that's kind of the overview at Scottish Government level. And in terms of where Scotland fits in the rest of the UK, we lag behind in the overarching structure of link working and social prescribing in general. England have a head of social prescribing with NHS England. Wales, it sits within public health, and Northern Ireland, it sits within the Department of Health. The GP funded link workers that were part of that manifesto pledge, that sits within the Primary Care Directorate. But we do not have that leadership that the other countries lie. So there's a lot of work, a lot of amazing work goes on the ground in Scotland, but there's a lot more that could be done to just really embed it in the health and social care system and really push it forward and have that have the role fully established in the multidisciplinary team, have patients aware, just raise this whole awareness of this non-medical approach to helping people in their lives.
That's really useful to know, because we've had other discussions across our network of talking about, well, how do Singing for Health practitioners, for example, make connections with social prescription, with those involved in social prescription, to make it more widespread. And there's been a little bit of a block, of a struggle, and it's possibly because there is no one person in a leadership position, or one person kind of leading the charge that they can go to say, hey, do you know about my work, and can you spread this out around all community link workers? So I hadn't fully appreciated just how complicated it seems to be on the ground level of uniting the community link workers and at the Scottish Government level.
It is, and we were fortunate enough that earlier this year, the Health, Sports and Social Care Committee at the Parliament were carrying out an inquiry into alternative pathways to primary care. And I gave evidence, as did Roseanne Logan from the Alliance and the Link Worker Programme. We also had Claire Cook, who is from Spring Social Prescribing, and Christiana Mellum, who heads up the National Association of Link Workers in England. And there was a really good, useful discussion around link working and the coverage, and how do people find out about what services in their area, and then the report came out from that, I think it was in October, and then it was debated in the Parliament at the beginning of last month, and at the end of the debate, Humza Yousaf made a commitment to discussing with Marie Todd about appointing a lead in Scotland. So hopefully it is all moving in the right direction. It's a tough time with the financial situation to start up anything new, but I don't think it would take a lot. We need it allocated to a minister just to have that ownership, and then start building from there, because there's a lot of resources, there's a lot of things already in place in England. You've got the National Professional Standards Body, which is UK-wide, and they've done a lot of work on link working. There's the National Academy of Social Prescribing. There's plenty of resources around the UK that we wouldn't be starting from scratch. But despite the lack of overall framework and leadership, there is a huge amount of work that goes on in Scotland. So I don't think we're lagging behind there.
No, absolutely not. And we can attest that as part of the Scotland Singing for Health network, we know that there's a lot of groundwork on the Singing for Health side. And hearing that there is that movement towards some kind of leader being appointed and framework being created in Scotland is really, really positive. So that's great to share with those who are in our network and for our listeners here today. So you've already mentioned the number of amazing resources, Alison. Is there research that ties into social prescription as kind of leading the work that you're doing as community link workers?
In short, no. Again, when the 250 community link worker programme was rolled out, it was very much left to each programme as to what they reported on. Scottish Government only asked for maybe half a dozen minimum core data requirements, and that would just be things around ethnicity, postcode, dates of birth. So it was telling you who you were working with, but not any more measurable outcomes or evaluation than that. So it's really been up to each individual programme to produce their own reports and evaluation. And again, this is something that we're highlighting through the Scottish Community Link Worker Network and the Scottish Social Prescribing Network, is that if there was a framework, there was a lead on it, then you could start asking for different forms of evaluation. In terms of actual research, there's a lot of interest around social prescribing from different universities. Claire and I, through the Scottish Social Prescribing Network, have been contacted by the University of the West of Scotland, who has spoken to 5 or 6 other universities about creating a Scottish social prescribing research hub, which would be linked into both the existing networks, just so that everybody's sharing knowledge. And I know a funding application has gone in to try and get that off the ground. We'll wait and see what comes of that, because something similar was set up in Wales. England, the English Social Prescribing Network do have a part on their website where people can submit reports and evaluations, so they're available for anybody to look at. But that's just kind of somewhere that you can hold information and you can access. And the other piece of research is the University of Manchester have began a £2 million research project on social prescribing and link working, and it's across the UK. So Edinburgh, I think it's actually Lothian and Glasgow are taking part in that, and it's Professor Stuart Mercer at Edinburgh University that's leading on that. It's at the very early days. I think they're just, in fact, we had a meeting on Friday about it, and it was just about that. How do we map services? How do we find out who's out there and contact leads? So, I think it's really, really interesting that there is this interest, and there's certainly enough work in Scotland going on for people to access. I think from either network's perspective, it's just about coordinating that and making sure everybody who's involved is joined up, because there is an awful lot of knowledge, and it's just like, let's not reinvent wheels here. Let's tap into the knowledge and the expertise that's already there. But I do think to ask for continued funding into something, then we do need the research and the evaluation behind it. In my previous life, I was in corporate banking, and that just is always, well, where's your evidence? Where's your data that then justifies the continued investment? And, there's going to be an awful lot of pressure on public funds going forward, but we know that this works. So we need to be able to evidence, and it would be the qualitative and the quantitative information, drilling. There's so many endless opportunities of what we can find out and what we can look at. And it all depends on the systems, the times and the resources, which always come down to money again. But there's certainly enough interest out there. I don't know if there's something that you're doing different in Glasgow, Deborah, or if you're involved in the Stuart Mercer project.
We've worked with Stuart in the past. I mean, certainly our programme kicked off in 2014, and we were one of those early adopter sites. And at that point, we were externally evaluated by a team at Glasgow Uni. I think this is a challenge that's always going to be around for the type of work that we do, because we don't have the kind of seamless outcomes. We can't necessarily have that kind of quantitative data, because we're working with people and communities. So even that kind of programme back then, it did look at the improved outcomes around health and wellbeing. I think, having come from a community development background, this is a kind of ongoing struggle for us to be able to kind of evidence what we do, and to even have that kind of buy-in around qualitative sort of evidence and research. How well kind of regarded is that, particularly within the kind of medical sphere? The GPs like stories, yes, but how do you upscale that? So we had produced at the start of our programme a series of records of learning that looked at different aspects of what we were doing, stuff around social determinants of wellbeing. Some of it's really difficult to capture, because you'll know from your own role that there's a ripple effect from what we do that it's very difficult to kind of drill down. You can have an impact with one family, but that can have a ripple with other members of the community, neighbours even. Stuff like that can take place over years. So how do you capture some of that in a way that's really going to support your evidence base for continued funding? I find that a challenge, but we're working with the HSCP obviously now in Glasgow in terms of our funding arrangement, and we've developed kind of new recording systems, trying to kind of capture a wee bit more of the range of services that we refer on to, the issues that are kind of coming to us. So that there's a wee bit of work that's changed over the last few years, and it'll be interesting to see how that kind of pans out in terms of that kind of the data reports that we're pulling in.
That's really useful to hear from both a local and then a wider national level. Now, Alison, you told us a little bit about the Scottish Social Prescribing Network, but I wonder if you could tell us a little bit more. So, for example, when was it formed, and what are the aims of the network?
Sure. It was formed in July 2020, and it really came about because Claire Cook, who heads up Spring Social Prescribing, which is a national lottery funded programme across Scotland and Northern Ireland, Claire put out a call to programmes, just asking people if they fancied coming together because we'd had such a shift in the way we were working, and almost just a camaraderie kind of way. And then it grew from there about really establishing a network, because nothing was in existence at that time. And the Scottish Community Link Worker Network wasn't established either. There had been talks with Scottish Government just before the pandemic, but of course everything was then paused. So it really came about from that, and a call for steering group members. So we started out, I think we had 7, all from different programmes across Scotland, and we also had a medical student, because there are social prescribing medical champions in each medical school, which came out of finding each other, and that's really driven by the English network, which is brilliant, and that just shows the importance of getting social prescribing in at that the medical degree level. And we also had a lady join us from Dumfries House, which is owned by Prince Charles, and they do a lot of social prescribing with the local community there. So we had a real mix. So the ethos was that we were all coming from the same place, and that we needed a framework within Scotland, because we recognised that we were lagging behind the rest of the UK. So really, since then, we were able to hold an event last September at Dumfries House, and Dr. Michael Dixon, who heads up the English network, came up and gave us really good feedback. We had a few people from Scottish Government join us there, and that then led to a really good working relationship with Marie Todd's team through Active Scotland. We then gained support of a couple of MSPs, and we hosted a parliament reception in June on social prescribing, and we had Marie Todd there, we had Jason Leitch, and we had the Director of Population Health come along as well. So it was a really good way to highlight the work that was going on. All the steering group members were there. There was kind of a selected audience picked, but probably the most important thing of that evening was that we had a link worker from Edinburgh, and we had a social prescriber from Spring stand up and talk through a case study, because there can be this misconception that social prescribing or link working is signposting, handing somebody a leaflet. If somebody is able to pick up the phone to an organisation or take themselves along to a group, they don't need a link worker or a social prescriber. So the two ladies that done the presentation, they did an amazing job of talking through the kind of issues they were working with, the work that was involved with the patient, and then the outcomes. And you could absolutely hear a pin drop in the Parliament when they spoke through them. So really, since then, we've had really good engagement with the Minister, and that's then led to different things happening. We had a follow-up meeting in November, and we've got another meeting planned in January, and hopefully with the commitment that the Health Secretary made about looking at appointing a lead, hopefully that's all moving along in the background. So that's really been the objectives of the SSPN. We're unfunded. We all do that on top of our day jobs, so it is a lot of work, and we would love to do more if we had time. I think every steering group member has very, very understanding managers, but understand that we've all got the same goals for where we want social prescribing to be in Scotland. So there is a membership. We try to host events once a quarter, and we try to keep people informed of any decisions. You know, just as you mentioned, Brianna, a lot of groups contact us saying, how can I get in touch with my local prescribing group? So it's a lot of information sharing, cascading things out, but also with the Scottish Community Link Worker Network, we've got a really good contact with NES, the NHS education arm, and we're working with them about accessing link workers and social prescribers being able to access the training on NES. Again, not reinventing wheels. If there's things that are already there, let's just share them and get that out. And it's trying to kind of break down those barriers as well, that a lot of social prescribers and link workers are employed in the third sector, so don't necessarily have this automatic right to any training within NHS. So just breaking down those barriers and getting everything accessible to all. It's been a really quick win, and I hope that that's kind of a platform for how things can move forward in the future.
Excellent. Thank you so much, Alison, and for giving us a little bit of insight into what community link workers do. And this is a good opportunity for me to ask Deborah. So as a community link worker, what does your day-to-day work look like?
One of the reasons why I love my job after 8 years still doing it is because it varies widely. And Alison, you'll remember from your time as well, that no 2 days are the same. And primary care can be such a busy environment. You know, it can be really, really fast paced. And you're working cradle to grave. I know certainly our programme we don't have any age restrictions. We're working with whole families, individuals. Certainly I come in the morning and I'm always based within the GP team. I don't work at home anymore at all. I check my referrals first things when I come in. Our GPs like to discuss in person our referrals, and I know that's not how it happens for everyone, but I have quite a small, really kind of family-like practice team. We have a lot of kind of real-time information sharing and dialogue. So when I do get a referral, I tend to get a lot more information around how that person might have presented, what they think might be going on underneath. The GPs won't necessarily open up that can of worms, but they'll have a sense that there could be more behind the initial referral reasons that they're kind of passing them on to me. So I will then call patients initially for an introduction, and then I'll bring them in for my kind of first appointment soon after. Usually my appointments are usually for an hour, and that's very much about having a good conversation. It's not about asking what's the matter with you. It's about what matters to you, and getting to know that person a little bit. Just actually kind of opening up, allowing them that space to kind of think about what's going on, what might be affecting their health and well-being. And even just having that conversation about well-being. It's not necessarily the kind of language that everyone will use. The same when it comes to self-management, having a kind of dialogue around what it means to self-manage a condition, and putting that kind of power back in the patient's hands. I'll kind of say to them, so you've got type 2 diabetes, you're maybe at the nurse twice a year for that, you're at the GP, 5 to 8 times, whatever. You live with it the rest of the time. And so having a conversation with them about what they do day to day, and often it's about helping people identifying the things that they're already doing that keep them well, and then trying to kind of build on that. But the day can really vary. At the minute, I was saying earlier before we started, I'm experiencing a lot of crisis presentations as part of my role, and some of that's been really positive in a way, because I had a woman just turn up to the practice last week. She had seen on a Facebook information board about benefits and additional support and advice, and she'd seen that GP practitioners in Glasgow were offering some support around fuel poverty, and she just pitched up, can you help? And I was able to, and that was being able to just be responsive then and there and say, right, come on in, and being able to kind of get that voucher to her, and then look at kind of, other wraparound supports, benefits checks, other kind of, onward referral that would kind of manage that. But you name the issue, we're going to be responding to it. People come with such a wide range of concerns, and at the minute, it's a lot of it's around the cost of living, and then obviously the impact on their mental health and well-being. But we take referrals for all sorts of reasons, and once you meet someone, there could be a whole other kind of tranche of things going on for them that the GP wasn't aware of. So, that we can then feed into their kind of their support that they offer afterwards, that kind of knowledge they have about what's going on for that person. I mean, that's the patient side of it. Obviously, I've got that kind of asset mapping approach as well, kind of maintaining those relationships across the community, having a presence in your community. So a lot of that's quite very much the informal stuff of just becoming well known in the community that you're based in, getting to know other practitioners in the area, people that are running the community centres, some of the key players, stakeholders, which can range from the super informal boxing clubs, gardening clubs, to the kind of more formal, I have relationships with all the schools, social work departments, addiction teams, even some secondary care staff, you name it, we kind of have quite a broad contact across health and social care services, and kind of making sure that we've got those links. And making time to visit new projects is always a big thing, because, the funding arrangements in the third sector changes so quickly. So even if you think you're aware of what a service is offering, you have to keep on top of that because it's constantly changing. And that information, and you'll know, Alison, one of the struggles we have with kind of, having a resource booklet or anything like that, an online resource, is the fact that it changes so quickly, and some of it's not information you would find online or that you would find in a resource manual of some kind. You need to maintain those face-to-face links within your communities and within the settings you're based. So that provides a challenge in itself, but it also means that, you do have those relationships. And if I don't know something, I know somebody that does, and, those kind of things, being able to just pick up the phone or nip across to the community centre and chat somebody's door, that's a really important part of it. A lot of the work I do as well is with the practice team. And they've really bought into the links approach. And so they're, I have we have pharmaceutical reps that come in, and then I come in the back and say, I've got third sector services to sell you, and I will make sure that they're up to speed. And I have a kind of weekly presence at the team meeting where I let them know the different things that are going on, how they can access. And it means then that they don't always need to refer people to me. As you say, Alison, not everybody needs the links worker. Some folk will be able to just access that from their GP. So yeah, it's very difficult to say what a day looks like because it can change so quickly. And it's so varied. So many different hats can go on. It's great. I certainly love it because it keeps you on your toes.
That's really useful insight. And can you tell us about how you find out about the arts health groups that are in your area that could support people?
Yeah, we've got, we have regular team meetings, both for our localities and then kind of wider. So, there's quite a few of us in Glasgow now. There's a large team, across the northeast where I'm based. So we share a lot of knowledge with each other, each kind of fortnight. And we're out and about, sometimes even just doing a bit of kind of walking. You will trip over things. But we have, various networks, as you say, for people that, we get information is cascaded to us through email networks. And as colleagues, we're always kind of in contact through our WhatsApp groups and kind of keeping abreast. It's a challenge because, as I say, things change and move quite quickly. People have come to know us, though, I think, in Glasgow. So if somebody's setting something new up, they're straight in there wanting to let us know about it. And that's taking time, but that's really, really beneficial. We'll invite a lot of projects along to our team meetings to provide a presentation on what they're doing to build those relationships. We'll quite often follow that up with visits, find out a wee bit more about that service. We don't want to be sending people to things blind. You want to be sending folk to a service that you really have a bit of knowledge of, being able to just name somebody there and say, no, don't worry, you'll meet Sophie at the group and she's lovely. That really makes a difference when it comes to supporting that engagement. So it's a kind of forever evolving, ongoing kind of process of, having those networks locally, whether it's through your email contacts or kind of presentations, wandering about, meeting other people. It never stops. You're always kind of on that kind of hamster wheel, if you like. But it is great that over time people have got to know us, and so we're in demand to present to. That seems to be where things have got to. We have a massive waiting list of guest presenters.
So I know that you're saying you've got a massive waiting list of guest presenters, but how do people get in touch with you if they want to alert you to a service or if they're setting up something new? We have a kind of a list of all our CLPs across the city by locality and GP practice, and we quite routinely share that as it changes, as it updates with any new staff. That's shared out across various networks. We've got integration networks that are very well connected. We use Twitter to some degree. I think that sometimes works out quite well. Social media, we're not necessarily Facebook based, but Twitter can be a great space to make connections. The HSCP, health promotion teams, there's various kind of networks available around the city that we'll make contact with us directly.
it's difficult, as you say, that kind of people phoning the GP practice isn't necessarily the best approach because of how busy the lines are. So it's usually email, and we all have our own mobiles. So that's something that our mobiles are given out across the board, and people taking calls from all sorts of different agencies. So a lot of it can be quite informal again. And that's maybe something we need to look at, is how do we have that kind of, people know exactly where everyone is. I mean, we might do that at a local level, but at a kind of higher level, I'm not sure if that's something that's easily happening right now.
What we do, we don't give out lists of our link workers because I think our link workers would never be off the phone to people. We do try to put a wee protective ring round them because they are a primary care resource, and we don't want to go upsetting GPs about their resources. So what we don't give out, we honestly, once a week I'm at least asked for a list, and I'm saying, well, I can tell you where they're based, but that's all. And we ask that any information comes through myself or our area lead or our the network manager, and then we cascade it. But when we first came along, we were very aware that people were like, oh, there's something new on the ground, how do I get a piece of them? So we had to say, no, absolutely a primary care resource. But what we did do before the pandemic was we used to hold quarterly networking lunches in the 4 localities in the city, and that would be anybody that had a kind of similar role or had a service that we would regularly use. And it was just 2 hours, as I say, once a quarter, and we'd put on a lunch, and we would have a few presentations. So it wasn't just the link workers that were hearing about these services. Lots of people within the community would find out about them. During the pandemic, we did a couple online, but they're just not the same because there's not that networking aware sandwich or a cup of tea or something. But we are bringing them back. I think the first one's in February. So it'll be really good to just get back out face to face. And although, I think everybody does have the message now that it is only primary care that can refer in, just that awareness that this resource is there and sharing information of what everybody does. And that's the best way of working, knowing that who's out there and who does what, so that we can all just work together for the best outcomes.
I think that's perhaps would be different in Glasgow because we do take referrals from out with primary care. So education, some of the local schools are aware that I'm based, other kind of social work teams, homeless teams, they will be aware. So they will now more likely ask people, what GP practice yet? Do they have a link worker? So there is a wee bit more of that happens with us, perhaps once we've been in a practice for some time where, addiction workers will know, even our local mental health teams, if they're coming to the end of a piece of work with someone, the psychologists routinely pick up the phone to me and make referrals for people in the next stage of their kind of recovery journey. So yeah, obviously I appreciate what you're saying about, that resource. It's not, we're not, we are a finite resource, but I see that as a real benefit. I get a lot of self-referrals as well. The word's out in my local area, and so word of mouth is huge. People will say, go and see Deborah. And that can work really, really well because for some patients, they're not necessarily accessing their GP team, but there are issues and health issues that are not being addressed. So it's about us bringing them in. So whilst we will reduce GP workload with some sort of situations, there's also folk who are not getting the sort of, they're maybe not engaging, and we would look to support that as well. So it's a wee bit, it does vary across the country, doesn't it?
It does, and I think this is where the Scottish Community Link Worker Network will come in handy about mapping what's out there, because it's not that one programme does it better than the other, it's just about how I would like to just see a mapping or some kind of gathering of data about who does what, because just as you, so we only work with over 16s because of the PVG checks, and we don't take self-referrals because we've had a couple of near misses with patients being in front of a link worker who shouldn't be. So we do try to reduce that risk of inappropriate things. But as I say, I think just getting a picture of what programmes look like. I was at a conference the other week and Roseanne Logan was there, and we were saying, wouldn't it be great if they had something with just a panel of the different programmes across Scotland and we could all talk through what we do, who we work with, how we evaluate, just to see the differences, because I know even though we're pushing for this ownership and a structure and a framework, we don't want it to be prescriptive, because we all do what we do because it suits our communities and things. So it would just be to have that overarching view, possibly funding, training, systems, generic high level stuff, and then each programme just goes and does what suits their communities best.
I would agree. Just speaking to our network members, part of the Scotland Singing for Health network, having a clearer understanding of, one, the fact that different local authorities have different approaches would be really useful. And then knowing, well, this might ebb and flow depending on the local authority, depending on the needs. And so being aware of that could be really useful for people who are trying to build their own types of Singing for Health groups or other groups that they're involved in, and knowing the type of environment around. And I say that because I know quite a few of our network members, they go across local authorities offering Singing for Health groups. And so they might not always be fully connected in or aware of what's happening in various local authorities and various communities. So just hearing the fact that there are differences is I think, a very powerful message. So thank you. So Alison and Deborah, what do you think the future of singing and arts health look like in Scotland? Is singing on prescription something that you think might be achievable?
I think it should be. I think take away from the financial situation and the pressures on GPs as it is just now, I think there has to be this kind of re-educating of the public about that a medical approach is not always best. From when I had a caseload and from personal experience as well, I've seen the benefits of a dementia choir. I've seen the playlist for life, what music can do to bring people alive. That is just fantastic. I've seen Breathe Easy groups with the British Heart Foundation, which I know does more than that, but that is a little bit of an element. And in Edinburgh, there's a chain gang for anybody with a lung condition. And it was that one of the ladies spoke us through and just said about how singing, I can't remember all the medical terms, but how singing was good for the airwaves, it reduced infections, different things. And I remember having a conversation with a lady that had COPD and she didn't know this and really liked singing. And I thought, my goodness, you could go and do something that you really like and it's really going to help your condition. And I do think it is about this educating people that there are things that you can do for yourself that will make you feel better, and just not this reliance on the GPs. And I know, I think it was earlier this year, there was a campaign on the TV about telling the receptionists what's wrong. Everybody complains that receptionists ask too many things and they're not medically qualified, but it's actually to make sure that you see the right person. So it is that whole education, even the GP, everybody's got a role in educating themselves or the people that they work with, but this move away from let's just use other resources, because there are definitely occasions where a prescription, a medical prescription, is not the best thing for you. It absolutely has its place, but there are alternatives that you can do. And when there's so much pressure facing our health system, I think we really do have to get that message across. But equally, the third sector and all those community groups must be supported financially to be able to help the health service cope. That's really important. And I know that's 5 years our programme's been up and running, and we came in and created this extra demand, and it has been manageable, but there will get to a point where it's not, and that needs to be taken into account with funding. And we have to get primary care or the wider health sector completely on board with funding for the third sector. And even some people don't like that term, the third sector, because it does sound like the poor relative, but our work is just as important as state services, and that should be recognised appropriately.
I absolutely agree, Alison. I think that is so important. I've certainly seen that over the last few years, a move away from statutory provision, which I appreciate, but I'm sometimes a bit suspicious when we talk about assets-based approaches, because it's often used to mean don't ask for any more money, use the existing assets you have. And certainly I'm seeing that the pressure on the third sector, the voluntary sector, whatever we want to kind of describe them as, they're often picking up the slack already for statutory provision that's overwhelmed. Certainly we're filling the gap as well, with waiting lists being incredibly long, and we're maybe supporting folk in that interim period when they're waiting on a service coming to kind of kick in. So I think the funding environment is really, really important to be talking about. But yeah, the power of art and singing is just, it cannot be underestimated. I remember working, and it's thinking about what it means to live well with a condition, and like you say, flipping that kind of idea of what that means. We're not going to cure you necessarily. That's not what this is about, but it's about people feeling empowered to manage that. I mean, I've got some amazing examples over the years. I remember working with a chap who had been given a pancreatic cancer diagnosis, which isn't usually a great outcome. It was certainly palliative. He had some palliative resection surgery, and his whole life changed when he learned how to paint. We took him along to an Impact Arts craft cafe. He went from strength to strength. He discovered this talent that he had no idea he had. I've actually bought one of his paintings. It was unbelievably amazing. So he was painting all the time. He started volunteering. He joined a walking group. He was giving back to his community. And we were getting these letters in from the oncologist saying, remarkably, this man's still doing well, and his tumour just stayed the same size. It did not move. And he lived for 5 years, which with that kind of diagnosis it's very rare. And he lived well. He lived so well. And it was only when COVID hit and all the groups stopped that sadly this chap's cancer reoccurred. And that kind of just told you so much about what was keeping him going, was all of these kind of activities in the community and his sense of well-being. And I remember when we set up the chain gang in Denison in Glasgow, we were seeing that people who were taking steroids on a regular basis, they were having these exacerbations. They were maybe getting anxious as well. Their mental health was impacted by that fear of not being able to catch a breath. My own father, certainly, I saw that. He had, he ended up joining the group. He had COPD. The confidence it gave him when he learned how to manage his breathing and to engage his diaphragm, and he was able to do so much more. People weren't accessing medication anymore. One GP in our practice was saying, well, I haven't seen that person for a year. It's like, that's because they're at the singing group and they're doing their exercises and they're singing in the shower. It was the impact. It's amazing to see. It's absolutely beautiful to see. It's sometimes a bit magical. I just wish more people could see it.
It's wonderful to hear your perspective, Deborah, and the fact that you've got these stories of people who are really benefiting from being part of arts helped groups, and in particular singing groups, because that's the message that we hear over and over and over again. But because it's like personalised stories and often anecdotal, it's not always captured in that quantitative data. And yet it's still really important to acknowledge. It's really important to factor in, and why Singing for Health could have a really important place in Scotland and in Scotland's health sector.
It's difficult to capture. We had a session in our practice recently with a respiratory consultant, and he was talking a lot about the kind of pathway for people where other health conditions might kind of overlap, and the kind of the poor outcomes that we can see. And one of the things he was talking about was the kind of cohort of patients out there who aren't yet having the regular exacerbations, but would really benefit and could be prevented even getting to that stage through singing, through, that kind of confidence approach and other kind of connections. How do we kind of tap into that cohort of people? How do we get that message out there that, you can almost prolong your experience of a condition at a certain level if you get the right support and the right access to those kind of singing approaches. So there's a lot of work still to be done, to kind of perhaps build that evidence base that this does work.
Well, and on that note, some of our singing leaders have been finding it difficult to access healthcare professionals and gain referrals to be able to publicise what they are doing. How might singing leaders best make their work known so that they might be able to be part of a referral route or become known to community link workers?
I think having a kind of the interactive map I've been hearing, we use that because I'll quite often be sharing what I'm learning with other practice members, pharmacists, the reception team as well, very much so. There's a kind of urban routes city food map provision in Glasgow. It's interactive. That's really, really great. I just kind of fire that out to various people at their fingertips. They can check via postcode what's available. Something like that, but specifically for singing, I think would be brilliant.
I think, and in addition to that, making use of local directories, and I mean, I can agree strongly with Deborah about you produce something and the next day it's out of date because a group's closed or it's moved or something. But we can only do what we can do. But just finding out local directories, you know, in Edinburgh we've got the Red Book, but there are other ones. But we're actually doing a pilot trial with a social prescribing system, and we are integrating that with the Red Book. So that it's easy for the onward referral destinations to be logged, and that helps us with our research and evaluation. But it would also give potential, and this is much further down the line if our pilot continues, that because this social prescribing system integrates with the GP system, that even if a practice didn't have a link worker, they would have a system that was integrated to their system that they could access information about local communities. So, I mean, that is a long way off and it is a bit of a dream, but that would be a really, really positive step. But in the meantime, just using local directories. I know that quite a few of our link workers do the Facebook page for their practice. So using that as an easy source of getting information out there, just following those. Quite a few link worker programs have websites or Twitter accounts. So again, Roisin at the Voluntary Health Scotland is mapping all that and trying to gather that. But it would just be doing a bit of knowledge gathering for these groups as well. I know Deborah mentioned there, you know, about all the knowledge gathering that the link workers do to find out, but also just finding out, you know, and it could easily go through either of the Scottish networks. You know, I've got this group, could you, who's in my area, or could you cascade this out? Because we do get approached by both local groups and national groups. So there's no easy answer and there's no quick hit, but it's just using all your contacts as best as possible to get it out there. But social media is the easiest one because it's cheap. It doesn't take a lot of time. You know, I could never run a website for anybody, but I can run a Facebook page for a practice. So just tapping into that.
I think even being aware of the fact that there are Facebook pages out there, that there's Twitter handles, there's things that people can tap into are really, really useful, even for those who are maybe looking for a service and they maybe don't have the confidence yet to get in touch with a community link worker or GP. They might be able to find things through social media means. But really exciting developments.
So I was just going to add that, you know, the GP waiting room used to be a great resource of information. And I think the first practice that I was in, I went in and had to take down posters that were 9 months old or something. But, you know, if we get back to having full notice boards, that's a good place. And if waiting rooms are ever busy again, it is a good place because people have nothing else to do but look on the wall. So just using every opportunity that you can.
I'm glad you said that, Alison, because I think, you know, in the community where I'm based, I've got good contacts with the community council and they've looked at community notice boards because there are people that just do not use social media. They're not tech savvy and we don't want to forget about those people. So they're looking to get installed 2 community notice boards that they'll keep up to date. And certainly my practice are very much back to face. So our waiting room is busy. And same as yourself, we're utilising that and, you know, making sure that there's information there. And that does really help generate some connections. So, yeah, looking at it from all different prongs.
Wonderful. And Scotland Singing for Health Network, we are doing our part to try and get the word out about the Singing for Health groups that are available all across Scotland, including we're building that interactive map, which should be available now. People can go there and they'll be able to see what Singing for Health groups are available in their area. So do go to our website and we'll include information in our show notes of where you can go and find that information. So before we come to the end of our discussion, is there anything that you would like to tell our listeners that we haven't discussed yet?
I think I would just, I know I touched on it earlier, but just this education shift in health, that GPs are not always the best solution. One of our lead GPs described themselves as having a toolbox of experts that they could look to, and acknowledging that now, it's a lot of hard work to become a GP, so it must be quite hard to acknowledge that you might not be the best person for your patient, but that they have a toolbox. The structures are there that, whether it's a physio, a mental health nurse or a link worker, that there are alternatives there, and to be open to those alternatives and being open to trusting your link worker or your social prescriber to give something a bash, because as Deborah touched on, when you have the knowledge that it's Jeannie that runs the singing group in the local community centre and there's 40 people go and they're all mixed age ranges, you reduce every single barrier that patient is thinking of, and you get that buy-in, and it's just empowering somebody to take a bit of control over their lives and do a little step that will just hopefully make things better for them. And I think we could all do with a bit of that right now.
I would just add that I think, that part of our role where we do supported visits and we physically go with people, I think that makes such a difference. And I've seen that be really low level where it's just crossing the threshold with someone and then they're settled and you're off. It can be such a light touch. It makes a huge difference. I think, offering more of that would be really, really beneficial.
It's been so wonderful to speak to you, Deborah and Alison, today. I think you've given some really amazing advice and just given us a lot more insight about community link workers and the Scottish Social Prescription Network and what you're trying to do on the ground. So thank you so much for our conversation today. Thank you all for joining us today. Next week, our very own research assistant for Scotland's Singing for Health Network, Dr. Sophie Boyd, and I will be discussing the themes that have arisen since the network was established back in March 2021. We will also share our thoughts on the future of the network. Thanks for listening. This podcast is produced by Scotland's Singing for Health Network, a project hosted at the Royal Conservatoire of Scotland, funded by the Royal Society of Edinburgh, and in partnership with the University of Edinburgh. For more information on our activities, please visit our website. Details are in the show notes.